Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Dr. Philip Gordon, and it's a huge honor for me today to introduce our guest, Dr. Russell Baer. Dr. Baer is a clinical associate professor at the University of Chicago, where he taught implant dentistry in the general practice residency and maxillofacial prosthodontics program, and conducted clinical research in implantology and reconstructive dentistry. Dr. Baer is an active member of the Academy of Osseointegration and the International Congress of Oral Implantologists. He's written numerous articles and lectures both nationally and internationally on implant dentistry. Dr. Baer's passion for implant dentistry also led him to the former Soviet Union, where he founded and serves as academic director of the Chicago Center for Advanced Dentistry. The center is the leading training center for oral implantology and advanced dental techniques in the former Soviet Union, with offices in Moscow, Kiev, Vilnius. Is that right?
Vilnius, Kiev, Vilnius,
Almaty,
Kazakhstan,
and Mumbai, India.
Yeah.
Okay. Well, throughout these programs, many American dentists have had the opportunity to teach and practice implant dentistry in the regions of the world, and you continue and mentor education programs there at your UAD location in Chicago. And I know you are one of the resident dentist doctors for the Chicago Blackhawks. Is that correct?
Correct.
Okay. So you've got quite a history here as it relates to your dental career. I guess I'd like to start off, maybe just kind of tell me what you're up to with your coaching and lecturing days, or your seminars. I know that's how I got introduced to you, is at one of your teaching seminars. So why don't you tell everyone what you're doing as far as lecturing and teaching these days?
Well, there's a lot of different areas of implant dentistry. Implant dentistry is not one specific component. It comprises a lot of different areas within dentistry. And so there's restorative, there's surgical, there's maintenance. There's a lot of different areas. And there always seems to be a need for advanced education or continuing education in those areas. So I started out mainly teaching general dentists about how to get started in surgical, but that tends to lead you into other components, whether it's restorative or advanced techniques. There always seems to be a demand and a need for further education. So ongoing now, last weekend I was in Utah giving a program mainly restorative driven. This weekend I'll be in Minneapolis giving a surgically driven program. So it really all depends on the need of the group, who they are, where they come from, what they want. We can put together custom programs that are good for the group. That said, I tend to have an underlying basic philosophy that I try to impact, and I think that can be summed up with keep it simple, keep it basic, and don't go beyond your scope. And wherever possible, keep in mind your mentors and use them. So I have a series of programs called the mentor programs, and these are mainly just kickoff programs that people can take and get into implant dentistry, but it's important that it's only a kickoff and they need to continue it. They need to get other opinions, other views, because there's a lot of different ways that we can do dentistry. So I think that kind of summarizes it in a nutshell there, the programs I'm giving recently.
Sure. Yeah, no, I know the course that I went to that you were instructing was a 2-day lecture with some hands-on component, and I felt it was a good balance between the diagnosing, the restoratively driven purpose behind it, and then the kind of the ins and outs of placement and surgical components, everything through walking through the motor and the drills and surgical guides and all that. So there's a little bit out there for everybody, but you have to always look at, the major scope and then what's the next step? How can you go deeper into each one of those? So
absolutely. And it's all about baby steps in life. Mm-hmm. There's no hurry.
Sure. So with so many years in implant dentistry, tell me how you got started into the implant dentistry field, and obviously that's changed over the years. So your progression through the implant dentistry.
Well, I kind of got into dentistry at a very good time for implant dentistry. It was right at the kind of the beginning of the scientific period of implant dentistry in the mid 80s. I went to dental school not knowing what a crown, a denture, or anything was. And I remember sitting there in class going, what's a crown? What's a denture? And the professors would talk because they had, experience in this. And it just never made sense to me, these removable prosthetics and partials and all these crazy appliances that I thought looked more like a fishing lure than something you should put in your mouth. And so I heard about implants during dental school, and right away that made sense to me. And I said, this is crazy what people are wearing in their mouth. Why can't we just put these implants in and do it that way? So I always had a fascination about implants. It was in middle of my dental career, there was the Toronto Osseointegration Conference where Brånemark first published his data on osseointegration that he started in patients in 1965. So this kind of led me to believe that there was a scientific component to it, and it was something that could, be a viable alternative to these crazy things that I was seeing in dental school. After dental school, I got into a GPR residency, which was very surgically oriented, and I found some basic surgical skills through that type of program. Went on to stay at the university, becoming faculty within the GPR, and implants were just getting going at that point, and a lot of people considered them experimental and invasive. Well, I looked at them as a way to keep me from doing destructive dentistry, such as grinding on teeth. So I looked at it right off the bat. I wanted to get into it, and at that point, it was very difficult for a general dentist or any dentist outside a major university to purchase the Brånemark system, which was the main one on the market. You needed to take a certified training program, which being with the university allowed me to do that. So I was a general dentist, able to go to these courses that were full of oral surgeons, a few periodontists and prosthodontists. And I always felt a little bit lucky that I came out of that academic setting as a general dentist. I also realized soon that, boy, if I could do both sides of this equation, the surgical side and the restorative side, I really would have more control of the end product. And I wouldn't have to depend on my surgical colleagues to understand exactly what I wanted and what I needed. And so I think it was a natural progression for me to jump in. And luckily, I was able to within my university setting. And there wasn't a lot of politics, shall we say, and a lot of people that were being obstructive to the general dentist. They were open and they were willing to mentor. So I was able to basically jump on board and start placing implants. So I feel lucky that I came up through that period where I was academic, but also had the general dental point of view to it. So that got me going into implant dentistry. And then I think that was the early acceleration period where we saw just lots of different products coming on the market, lots of different concepts. And so it was an exciting time to be in that ever-changing area of implant dentistry.
Yeah, when you spoke of that Brånemark kit only being sold to surgeons, I know placement of implants was very restricted for a long time. So, I do think you would be fortunate to be able to get into that at that time, as it was and still somewhat is kind of closed door in some of those major programs and even through the major implant selling companies, very specialty driven. But I think those barriers are being broken down more and more. And I think it's interesting how you were really ahead of the time at that time, as most of your colleagues probably didn't get the exposure or the opportunity to grow in those areas.
Yeah, that was a big part, being involved with an academic center. I had some credence, shall we say, being a general dentist. It's not, we don't have advanced residencies, even though we had GPRs and things. We didn't have that shingle that legitimized us doing things a little more advanced. So at that point, you really needed to have some foundation to get involved with these organizations. I remember signing up for the Academy of Osseointegration back in the late 80s. And, it was a rare general dentist that they even allowed to become an active member. You had to have a academic following. And, the courses were definitely prohibited unless you had some type of academic center or some way to get in. So, and some of this politics continues, and there's still people that feel that general dentists shouldn't be doing it. And I think that's destructive to the entire profession. And I think we need to be open, and we need to have more mentoring. It's interesting. I got involved in the mentor program, which came out of Europe. Europe doesn't have quite the same specialty organization that we do in the United States. And it was in the mid 90s or early 90s where over in Europe, this mentor program started, where a specialist or somebody with advanced training would get the group of referring dentists together and teach them how to do the basic cases, teach them how to do the basic placements, the onesies, the twosies that were straightforward, because there was plenty of cases that they would get referred from this group of people, the more advanced. And this is the whole idea. The mentor is you'd have kind of an advanced person mentoring a group to do some of the more basic things. Well, this was brought over to the United States, and it fell flat on its face because there was a lot of resistance from potential mentors for allowing other dentists to get involved. There was more selfishness, shall we say, of I want to do all the cases. I want the easy and the hard. And so the mentor program took quite a few years to really get its feet on the ground here in the United States. And it was a difficult climb to get general dentists trained. And it still is to some degree. It's getting easier and easier, but there's still walls being put up that saying that general dentists shouldn't be trained in this. So it's, I think, hopefully we're beyond that, but I run into it all the time still.
Yeah, and that's half the reason I've started this podcast is to try to break through some of those barriers, as I've found some of those to be true over my 7-year training in implant dentistry. It's been an uphill climb, and I'm trying to latch on as many mentors as I can. You being a definite big one in my mind, but. Yeah, it'd sure take a lot more of you, hopefully, like your kind out there to push this thing forward. So really appreciate the work you've done kind of breaking the ground in that front for everybody. So.
Well, thank you.
Yeah. Now,
continue. We need some more superstars.
Yeah, we do. Now, you talked about some of the academies. One of my things I wanted to bring up was your opinion of the Implant Academies, which ones you feel are a good spot for general dentists wanting to place and restore more implants. I know there's a couple of the big ones. Maybe you can touch on some of those.
The general dentist is getting much more invited into these academies now. I think the American Academy of Implant Dentistry really is a great all-around organization for not only the general dentist, but it has the specialists. And when you're at those meetings, it seems that there's this feeling of not having the different specialists, but we're all as one. And so I really feel that's a great organization. The International Congress of Oral Implantology, ICOI, similar. I think it's very inviting to the general dentist. They have a fellowship program. Both of them do. They give advanced standing certificates for people that go through the fellowship and the diplomat procedure. So it's a great way to kind of have an outline for advancement within the profession. From a strict scientific point of view, the Academy of Osseointegration is kind of the scientific wing of implantology. And if somebody is interested in seeing from a scientific point of view the field advance, I think that's a good one to be a member of. But it tends to be the most political in the sense of specialist versus general dentist. But that is where most of the science is first distributed through the Academy of Osseointegrated journal, the Journal of Oral Maxillofacial Implantology, JOMI, which is considered the top scientific journal. Beyond those major national organizations, there's a lot of local study clubs. Seattle Study Clubs, I think, is a wonderful organization. I think it's a great thing for dentists to be involved in the Seattle Study Clubs and other local study clubs that could be a general dental study club based on implants. I know that throughout the United States, I periodically get invited to come lecture to some of these study clubs, and it's just a wonderful thing to see a group of professionals trying to get together and advance themselves in a specific area.
Yeah, no, I agree. I'm part of the Kansas City Seattle Study Club here, and I think that's been a great mentorship path for implantology and just dentistry in general. So I think more of those study clubs with senior leadership are a great way to do things. So I think that really explains those academies well. I mean, I think they all have their different focuses, and I think that really kind of explains those three big ones well, I would say.
Yeah. And, I could go to a meeting every day of practice, but at some point you have to get down and you got to do it.
Oh, absolutely.
There's a ton of good education out there, and you got to ask around and pick and choose and find the ones that fit where you're at. Many meetings nowadays, it's difficult to go there and actually get trained because you've got 40-minute lecture where people are getting up there and they're showing this one concept, and a little bit of it is show and tell, and they're highlighting it. That's a great type of meeting, these national meetings, to kind of set the barometer of where you're at. But I think it's also important to look for these intensive 1, 2, 3 day courses where you're actually doing hands-on learning and you're actually getting in there in depth into these topics. So there's a combination of those two is what I use to keep my skills moving forward.
Yeah, and I think that's a great point, because sometimes they can hit, okay, this is a 30 or 40-minute presentation on how you do this one specific type. But, what I liked about the one I went to at yours was it took someone who says, let's assume you've never placed or restored an implant, and walked you A through Z on everything you would need. But you can only do that if you've got 2 or 3 days in a row, right, and can dive into, 20 hours of material. So I guess with that being said, what other courses do you know that are out there or that you have taken that have helped you or that you could recommend towards someone looking to grow in implant dentistry? Any other that you're aware of that would be, great paths for people?
Well, I see more and more basic courses being given all over. And, I don't know all the speakers. And a lot of it is you got to have faith in the person who's running it. There's also a lot of them that are commercially driven, put on by the implant company. And you got to be careful that it's not just a sales pitch. So I look for practitioners who have been around a little while, and one like Arun Garg, he has a commercial pitch, but he's been around and he does pretty good programs. So many of the companies are sponsoring programs, but it tends to be just, here is our implant. This is how you place our implant. And it's not kind of a generic education. So you have to be careful with that. When you start getting into advanced techniques or semi-advanced techniques, you got to look to some of the stars. And, Michael Picos out of Florida, I think, puts on some of the most amazing surgical programs that are available. And I've gotten to know Mike a little bit, and he is a diehard student himself. I was taking a program in Budapest, Hungary, from a doctor over there, and he happened to be, one of 12 people that was in the course. So I was just so impressed that here's a guy who could just have people come into his facility and he's out learning. So I think when you get into the advanced stuff, I think a guy like Mike Picos or Sasha Jovanovic with his Guide Institute in LA are really stars. There's a lot of general dentists, not a lot, but there's quite a few general dentists on the lecture circuit. And I think it's a good idea to get a couple different opinions, even if it might, be different or bad, but you have to see other people's opinions. And the best way to do that is join a study club group that brings in speakers such as Seattle Study Clubs, or go to one of these national meetings and see some of the speakers that are on the podium, and then find out if they give programs in their hometown or at other areas, because quite a lot of these guys who are up on the podium also will give more in-depth programs, and you need to kind of look at them in a test drive, so to speak, and find out, wow, do I relate to this guy, or is he completely opposite end of the spectrum that I am? There's a lot of different ways to look at implant dentistry, and there's some people that just want to make it more difficult, and there's other people that try to simplify it and bring it down to earth. And so I think a great thing is to go to these national meetings, pick out a few of the guys who you seem to relate to, and then check into their programs, which they'll usually have them listed.
Yeah, you made some good points there. I think, like you said, looking for people who are teaching the anatomy and physiology concepts and how to integrate the implants, and not just someone who says, okay, if you buy this kit and do this, you'll make it. I mean, obviously everyone's got their preferences to what instruments or implants they like, but that shouldn't be the focal point of the lecture necessarily. It more should be how the information and science is behind it and backing it, not necessarily, pushing the product. So that sometimes that's tough to decipher out there through,
it is
through things. So you want to get, to the truth of the matter. So
yes. Yeah.
So let's see here. How are you using dental implants to restore patients in your own practice? Because I know you've got a busy practice and see a lot and do a lot. Tell me about, what some things you're doing in your practice, what types of cases you're doing, and obviously what you're seeing up in Chicago there.
Well, through the years, we've created somewhat of an implant specialty general office. And so we get a lot of referrals, not only from other doctors, but from patients. We have a very big web presence, advertising and through the web. And we get people, every day coming in that need full mouth reconstruction, need full mouth. They might think they need all their teeth out. I enjoy telling people, no, we're not taking your teeth out. You got Mother Nature's best implants, and we can make those work. So we have a fairly, shall we say, advanced implant practice, but that said, we also, within our practice, have associates and other doctors that have regular general dental practices, and every day they're faced with patients that are potentially going to be losing teeth, and implants could be an option for them. And so I think every general dental office in the United States is going to run into this, where they need to have that within their armamentarium. They need to be able to give their patients the option of a dental implant. So I look at practicing dentistry without implants as something I couldn't do, because I need to offer that as an option to my patients to give them proper informed consent. When I'm looking at a missing 19 or missing number 30, which are the number one missing teeth in the mouth, I can't imagine my list not having implants at the top of it, and the bridge below it, especially if the bone is adequate. I see a 3-unit bridge in the mandible posterior area is borderline malpractice now with the way we have implant dentistry, with mandibular flexure and the need to grind down teeth. I think implants is our primary thing. And every general dentist should be seeing or will be seeing that within their practice. So I think that's an area where I think if they're interested in getting into implant dentistry, they should start looking at those single missing molar teeth, the posterior teeth. I've always taught that to be the area where you first want to look.
Yeah, there's definitely enough of that out there for sure. And, if you're not even placing implants, you should definitely be treatment planning and referring those. So that's a great way to get into implants, is start recognizing and treatment planning and, getting those treated as a specialty team approach and, getting comfort level down that way. Now, you do a lot of single, multiple, and even full arch rehabilitation. Can you talk a little bit about your system for that? Are you doing sedation? Are you doing kind of all on four practices? What kind of high end complex care are you providing in your office?
Well, we have a bit of all of it. I don't want to get into numbers, but we're placing a significant amount of implants every year. And the majority of that still is the ones and twos. But, that said, we also advertise and have a significant amount of the full mouth reconstruction, whether it's all on 4, all on 5, all on 6. I don't want to get into the numbers because I like to individualize it. We do that fairly regularly. I would say, there isn't a day that goes by that I don't have some all on 4 type procedure at some stage through just thinking of today in the office. There was probably 4 different steps within an all on 4 that I saw patients at. So it's a very popular alternative to dentistry. And I think it behooves all of us general dentists to be able to identify the terminal dentition, be able to start having the discussion with the patient. Well, what do you want to do? Are we looking at dentures, or do you think that we can maybe be a little more proactive and start getting implants in before everything goes south and plan a nice transition from teeth to implants? So there's a lot of that discussion that goes on in our office. The all-on-4 has been a wonderful thing in eliminating some of the more advanced procedures. We're not doing as many open sinus lifts as we used to because we're looking at what we call graftless solutions. Can we put the implants in at an angle, still get posterior occlusion, but angle the implant away from the vital anatomy? So that's been kind of wonderful. Closed sinus lifts, which are through the osteotomy of the implant, instead of doing a full lateral Caldwell-Luck procedure, has diminished that procedure. I've always thought that was one of our more enjoyable procedures in implant dentistry was the open sinus lift, but we seem to be trying to eliminate it all the time, which actually is a good thing for the patient because it shortens treatment time and it hopefully then will make it less expensive for our patients. So, every day we're doing these advanced procedures, and it really all depends on what the patient walks in on, what their need. I had a new patient in today, and I had to write out 3 options. Option 1, being upper and lower all on 4. Option 2, a combination of saving teeth and putting in posterior implants, and then saving teeth, removable partial denture. I always throw in another option, upper and lower full dentures, but I tend not to do many of those because we get people into implants. So and in the end, this patient took for his upper jaw, he took the more all on 4 plus meaning we'll probably do 5 implants on him. And the lower, we're going to be doing more conventional style So I think it's all part of our informed consent is to sit down and treatment plan these cases with all options for our patient, including the advanced ones. And if you're, as a general dentist, not providing it, you at least need to know it as an option so you can properly discuss this with your patients.
Yeah, I'm seeing a lot of non-traditional treatment plans come up more and more as the technology of implants and guided surgery and restorative options and all that continues to advance. And the need for this is increasing as the baby boomers are retiring and not wanting to settle for traditional dentures or gumming it like their parents. You know, there's definitely a high need for implant restorations. And like you said, terminal dentition. How do we phase that to where we're not just pulling all the teeth and going straight to dentures? Are we saving certain teeth and staging it to keep bone? And, you know, where are we putting implants and how many? I mean, I think there's so many options nowadays that it's not just we're going to crown every tooth or go to dentures. It's a progression. You have to think with the end in mind and, you know, treatment plan over months to years and take them through phases. So there's definitely a lot to be aware of and a lot of moving parts to think about.
Absolutely.
Yeah. Now, one of the other things that I think it's under talked about would be, you know, the bone grafting and site preservation. When people talk about implants, they want to do implants and things like that. I think, okay, my first step now is thinking we got to get better at bone preservation and grafting and preserving what's there. So talk how you, for a moment, how you approach, you know, bone nowadays as obviously you've got to have that first before we can even talk about implants.
Right. And, you know, most of the people in a general dental office are people that have the tooth and they're faced with losing it. And it's typically a older root canal treated tooth that now, you know, has come to the end of its lifetime. And so you can have the discussion with your patient while the tooth is there. Do you want to have a tooth back? And most people, when they do have the tooth, say, of course, I'd like to have a tooth. And you say, well, you know, because of the damage that's been done, because of the infection, typically, we're going to need to help build some of that bone back so we can give you a tooth back like Mother Nature. So I'm doing a lot of discussing with our patients on getting the tooth out, restoring the bone that has been lost, and then coming in with a dental implant. And it's a everyday conversation. Socket grafting, I think, is a mandatory thing that anybody who's pulling teeth needs to be having the discussion of socket grafting with their patient to maintain the bone if you're going to do an implant. Much more critical in the maxilla than the mandible, but even in the mandible every day, it's a good idea to be taking these teeth that are have created bone loss and rebuild that bone so that it makes the implant placement more straightforward. So socket grafting, I think, is a big part of our implant practice. And, you know, once again, I try to get early users of implants to go out, learn how to socket graft 19 and 30, learn how to place a single implant in 19 and 30, and then learn how to restore that properly. And that, to me, is the greatest way to take your first step into implant dentistry. And socket grafting is part of that first step.
Yeah, I couldn't agree more. I think the first step in your implant training really is learning how to extract teeth very well without damaging, atraumatic extractions, and how to do really good socket grafting. Now, when you say socket grafting, what would be your ideal scenario, whether it's a 19 or 30? I mean, when you say socket grafting, what do you mean specifically by that?
Well, what I'm trying to do is rebuild lost bone. I'm also a big advocate of immediate placement of implants, and that's part of my programs. And if I have buccal lingual bone, I consider my implant part of the grafting material that can go in the middle. But socket grafting by itself usually means that I don't have part of one of those walls. Typical, the labial wall has been lost due to an infection. And so the socket grafting is going to help me rebuild that labial wall that I need to contain my implant. So we'll be using some type of typically allograft, which is kind of the material of choice nowadays. I like various cadaver bones, and we will place them into the socket. It's a fairly simple procedure. If you've got a fairly intact socket, a membrane covering I don't feel is necessary. The more damage there is, the more need there is for a membrane to contain that graft and create kind of a new bony envelope for you to grow bone. Remember, the graft is just a scaffolding for the patient's own bone to grow into, and the more that it resorbs, the more of the patient's real bone I have. So socket grafting nowadays tends to be more just allograft, but there's xenografts, which are mainly cow-derived if you want to increase the density, meaning you have a bigger defect and you need it to take a little longer to grow. So those are things that I think material choices, there's all sorts of things out there, but I try to keep it simple, and I think allografts are the most simple approach for the standard socket.
Yeah, I mean, I think you nailed it. Definitely some sort of bone graft. The membrane, from my experience, is normally, like you said, if there's an infection and part of the facial wall is deteriorated due to that or the trauma of the extraction. But I definitely think that socket grafting is a must. Absolutely. I don't even think about pulling a tooth anymore without thinking of putting something in there. And if the patient refuses and won't pay for it, half the time I place it myself and think, one of the two of us is going to benefit from this later. So, I think it's definitely something that, unfortunately isn't taught in school. And, so the training on that is very limited to new grads and young professionals too. So I think, that in and of itself could be a whole course in training and topic for young implantologists out there, is just how to preserve what's there.
Yeah, the one of the first things that I get into on my mentor course before we start talking about implants is socket grafting, because I position that ahead of time. You've got to have adequate bone if you're going to get it implant placed fairly straightforward. And if you don't have the bone, you better refer it out to somebody that knows how to get the bone. So.
Mm-hmm. Yeah. Now, how are you incorporating 3D cone beam technology into your practice, and how would you recommend at this point others be utilizing that technology?
Yeah, that's a great question, because it is, that type of technology is all around us right now. I purchased our first CT scanner, cone beam CT scanner, in 2006 or 7. And we were kind of figuring out, how many of these do we need to take each day to pay this nut, and what is our charge going to be for this? And it wasn't too much after we purchased it that we started actually giving away quite a few of these CT scans, because they were an amazing practice builder and educator for the patient in showing them what was going on in their mouth, from the abscesses to the loss of bone to the positioning of where we wanted implants. And the advanced software now even makes that easier. Is that I can't imagine doing dentistry in general without three-dimensional capabilities. That said, yes, there is a certain price point on these things, but I think we're seeing that it's well worth it. Even if you're not doing implants, I think there's reasons that a general dental office can have 3D cone beam CTs for endo and for ortho and various other reasons. They're amazing. But I look back at when we were practicing implant dentistry basically off of a panoramic, and I kind of chuckle how lucky we are, so to speak, that we didn't have more problems because we really didn't see the whole picture. And now with the CT scan, I think we are doing more cases because we can fully understand it better. But I think in general, we have a much better view of the oral complex. And, I live in a three-dimensional world that's backed up by all my softwares and technology. And so my head has to follow all that. And so I think I have become a better practitioner by living in a three-dimensional world, not only in the patient's mouth, but in the technology we use for diagnostics.
Yeah, there's no doubt. As soon as we purchased our CT scan and started taking cone beams, I give more away than I charge, because it allows me to see and diagnose and treatment plan better. And there's so many things that I understand more now as a practitioner that I didn't have any conceptual idea before the three-dimensional world. And like you said, even if you're just doing root canals and ortho, or from a diagnostic, there's no such thing as phantom pain anymore. I mean, that doesn't exist. And the understanding of anatomy is mind blowing once you realize how much you've been missing and now what you're seeing. So I definitely agree with you there. But how are you using that in regards to surgical guides and things of actually placing your implants?
It's really made it a lot easier nowadays to create a surgical guide. There's a lot of cases that I think are better done with a surgical guide. And part of the reason it hasn't caught on like it should have is because it takes time. And time is money and effort. But now the software is so simplistic that it really is a great diagnostic benefit to sit there with your three-dimensional image and actually place an implant on the computer. Once you've done that, the way the software is set up nowadays to actually produce a guide is very simple. So it's more just clicking a couple more buttons, and you can get anything from a 2mm pilot guide, which is something I use a lot of. It's simply it sets my pilot, and then I might open up the flap to manipulate the soft tissue, but at least I have that initial guide done, to fully guided surgery where it's flapless and it's fully guiding the implant into position. So the software advancements are amazing. There's a lot of free software now. So I don't think there should be too many obstacles for people doing more of guided surgery, which is really a safe way to get into implant dentistry, or at least have that as part of your armamentarium. So guided surgery is a software-driven part, and so I find that the young doctors are picking up this much quicker than some of us old guys. So hopefully it will continue to advance.
Yeah, I absolutely agree with you. I actually use a pilot guide almost regularly to place almost every implant that I place. And that 2mm pilot gives me the exact depth and the exact angulation that I had already treatment planned on the model and in the 3D model. So I've already seen the surgery. I've already done it in my mind. I've already planned it on the computer. I set that 2mm pilot guide, and then I flap and then place my implant, and you have total control of the case. And there's really so much more predictability when you can look at, where the restoration is going to go and work backwards, and you're taking all the error out of that. I think it's not a crutch, but more of a precision tool. I want to be so precise in my placement that everything is calculated from the beginning to end.
Absolutely, and the prices have come down quite a bit on these 2mm pilot drills, that it shouldn't be a obstacle for practitioners to use more of them. I always say to people, I'm the expensive part of the formula. Things like guides and doing it right are the inexpensive parts. So, if I'm wanting to do a case for somebody and the money's an issue, I'm not going to take away the guides. I'm not going to take away grafting and do it less precise. I'm going to maybe take it away from my side of the equation. So I think we need to get people to look at that, not just to financial and tech barriers, but look at it as a better way to practice.
Yeah, because there's people that'll help you plan the guide, and I just pass on the price to my patient. I don't upcharge it at all, and I say this is part of the deal. And so it just goes into it. So
I've got a couple kids. I've thought, that they love sitting in front of the video games so much that maybe I should hire them just to learn how to plan these cases, because that's really a lot what it is. You go to a laboratory nowadays and they're hiring these tech guys because they're not waxing up crowns anymore. They're doing it virtually on the computer. So it's the same type of thing with our software.
Yeah. And I work with my same lab tech who's planning my crown, and we're planning the implant and we're planning the guide. So, we know where this case is going A to Z before we start. And so there shouldn't be any glitches at that point if everybody does their job right. So, and it's definitely made my life, and it shortens my implant placement time to about half. It was an hour and now it's 30 minutes. And so
absolutely,
you can take that and do 2 implants when I could do 1. So
right. And it takes that stress level out too.
Yeah. The stress from a basic implant case is gone. And, if I can get them numb and I can get a guide in the mouth, it's kind of a no brainer.
Exactly.
But you still have to do the little things right, but it definitely takes, that next level of confidence that I think everyone should be doing.
Yeah.
So if I could ask you some of your kind of your best 3 practices in implant dentistry, what are some of the 3 most important things that you either see in implant dentistry and in particular how you're using them in your practice today?
That's a pretty broad question.
I know it is. What are the 3 best things that you do in your practice that makes things go so smooth? If you say, look, these are the 3 things I can't do without, or the three things that have made all the difference to you practicing implants lately.
Well, nowadays it's 3-dimensional diagnostics are really primary. I can't imagine doing that. I shudder when I have a glitch in the computer that runs our CT scan, because I think we'd have to close the door. We get so reliant on 3-dimensional data, and then on the flip side of that is my staff. I think if you're going to be doing these type of treatments, you need to have somebody such as a treatment plan coordinator who can sit down and spend the time that you might not be able to explaining it and using models and drawings and diagrams that can really bring it down to the basic concept so your patient is fully educated. When my patients are fully educated, there's less problems because we've talked to them about what their expectations are versus what reality is. And I find the biggest problems I've ever had are where I didn't fully explain to the patient and they thought one thing and I did another thing. And so having a treatment plan coordinator get in there and spend the time with these, shall we say, more advanced cases is really a big benefit to any practice. I'm sitting down all the time with my treatment plan coordinator who really has to understand dentistry, but she has to be, or he has to be a very good people person. I try to stick into the practice side of it, but when it comes to the finances and everything else involved, it's so nice to rely on a staff that can do that. So that really has, my 3-dimensional data, my staff has really made things easier. And also, I think you need to have a vision to do things right and not be in a hurry. And patients are coming in and they want teeth today or tomorrow. There's all these concepts of teeth tonight and so on. And sometimes you need to just say, hey, let's slow it down. Let's do things right. Let's not try to cut corners and take it a step at a time. And patients understand that and they'll feel your caringness for the process to get them teeth. That said, you also have to be a good clinician in the sense of getting them temporaries and getting them teeth, as soon as possible. So I think that's important that we don't try to push biology, let biology do its thing, but understand the needs of our patient. We have a lot of conventional techniques to keep people into teeth while we're doing some of these more advanced things. So I think don't be in a rush. Explain everything to the patients and stick to the basics initially, and don't work beyond your own envelope of education. Stay within that and ask for help. It's so nice to be in a group practice where I can pull somebody in and get a second opinion. It keeps you grounded.
Yeah, absolutely. I agree with you on all those. The cone beam is definitely something that I can't practice without. And even if I couldn't have one in my practice, finding a scanning center and sending patients to a scanning center, you can find a lot of those in most major metros anymore. And
absolutely, a lot of orthodontists and they're not going to overcharge you. They just want to have a relationship with you.
Sure. And the dedicated treatment coordinator, I think, is a must, because these aren't, A plus B equals C cases. These aren't your insurance covers this and that. These are some of the bigger cases or more extensive treatment plans for these can be, significant out of pockets. They're expecting, some life-changing dentistry. So the treatment coordinator position is never been more important, I think, than in a practice that employs implant dentistry, because that reality and expectations and conflict model, if you don't have those expectations set and, all those talks ahead of time, they're just excuses on the back end. So someone who can really nurture those patients, work through the financials with you, I think is your most valuable player on the team sometimes.
Yeah, absolutely. It's so critical. And keeping in mind that it is a team. It's not just on your shoulders. It's so important to have your assistants and your hygienists and everybody on the same page, because it really makes it a more simpler process to bring these people through everything. It shouldn't really all rest on one person's shoulders.
Yeah, absolutely. The dental team is important with that, and I think that's the more complex the care, the more team has to be on the same page. So, these implant cases, even if they are immediate extract and place, you're not restoring for a month. So there's always 3, 4, 5, 6 months in these cases. So it's never quite as quick as a filling or a crown. So there's going to be multiple visits and different levels of temporaries and things like that. So.
Absolutely.
The team model is definitely more important in this type of dentistry.
Yep, absolutely.
The relationships are definitely where it all starts. So, well, I guess last question here, and I'll let you go. So, you being a well-rounded person and been around the world, who else do you think would be a benefit for me to interview and talk to in regards to the practices of implant dentistry?
I also come from the old school where the Carl Misches, I would say, but, Carl's, who's a wonderful educator, has a lot of his own philosophies, not always in line with mine, but I think that's the type of person you need to look at and find somebody, Carl being perioprost, but he really operates like a general dentist. There's a lot of, Jack Hahn was another one of my mentors. This is kind of the old guard that are coming through and starting to retire, which is a shame, but that's the type of person you need to go out there and look for. There's a few young people, but I haven't really met a lot of them that, I've taken their course with. They've been in my courses. What I really appreciate is some of these CEREC people or technology people, the CEREC online, the Tarun Agarwal, the guys like that. I think that is a really good type of person when they start talking about implants, because they come from a technology base. I also think it would be a good idea to talk to some of the laboratories. Glidewell is really big into the implants now. And I think it'd be an interesting thing to maybe interview the head of their implant division to see where they think the field is going and how many general dentists they're seeing versus specialists and so on. So I think there's lots of people out there, and it's hard to come up with, who is the next best one.
Sure. No, absolutely. I agree. We'll definitely try to knock on Carl's door, but I don't think he's got time for me on his schedule, but I'm definitely going to call.
Carl's got brain cancer, and so he's kind of slowing down. Yeah, and it's a shame because he's been such a powerful force in implant dentistry, but he's still around. You never know. He might want to take your call.
I'll give him a call, but I definitely had Jack Han on my list, and Taran, and I had made a point to call some various labs, and I definitely will make sure Glidewell's at the top of those because, as I alluded to earlier, I think that whichever lab you're using, it's paramount to have precise communication with implant restorations and guides and all that, because the dentistry we do relies so much on, like, talk about that team approach, and one of the critical components of the team is your lab. And if you don't have a great relationship with that lab, if you don't know what they're going to deliver, if you don't give them, if you're not asking them, how can you do better? How can we move this margin? What type of temporary, how we place the occlusion? If those things aren't planned and thought out, it's, the case is doomed from the beginning. So, I'll definitely give those guys a call and see where I can get with that. But, I just want to say thank you for spending some time with us today, and, definitely look forward to meeting up with you again soon. So I'll look for you out there on the circuit and check your courses. And if you are ever in Kansas City, feel free to look me up, and maybe I'll convince our Seattle Study Club leader to get back in the Kansas City metro area at some point.
I would love that. It's a great town, good barbecue.
Yeah, good barbecue. So I'll look an eye for you out there, and look to talk to you again soon. Okay.
Okay. Thanks so much. It's been a pleasure talking to you.